joining our first Vaccines for Adults webinar in 2020. We have a very full agenda, and I wanted to go ahead and get started. We will start with, so before we get into the actual content, just a reminder on the setup of this call. As you all dialed in, you should have noticed that your lines were unmuted. Right now we have placed everyone on mute, and we are now all your lines will be on mute until after the presentation. At that point, what we will do is open all of the lines, and then you will have to self-mute at that point. But that will give an opportunity for all of you to ask any questions that you may have for Dr. Hoover on the adult immunization schedule, to either myself, Nisha Gandhi, or Anya Gutman around the program, VFA program updates that we'll be doing towards the end of the webinar. All right, so we also have the chat function, so you'll see on the screen. If you have questions as we move through the presentation, feel free to go ahead and submit it via the chat, and we will be keeping track of those, and we will address them after the presentations are completed. Okay, so let's move on, and as I mentioned, we will start with a look at the current ACIP recommendations for adult immunizations. These were just published in February. Dr. Corey Hoover will cover those, and then we'll move into program updates and then reminders. So at this point, I'd like to turn it over to Dr. Hoover, who's here at the immunization branch, and we'll be reviewing the ACIP recommendations for adult immunizations.
Hi, everyone. Thank you so much. It's great to have the opportunity to review the adult immunization schedule, including 2020 schedule updates with you. The maybe more informal title of this talk is, what shots should I order? And as all of you who care for adult patients know, that answer might be a little bit different for each patient that you see, and sometimes sorting your way through the adult immunization schedule can be complex. The schedule is visually complex, and there are a lot of footnotes and other elements to it. So today I'm hoping to take you through the tables in some detail to help to increase your comfort level with that, and also discuss indications for various immunizations. There are a few resources that you may be interested in aside from the ACIP schedule tables, which are readily available online. One is a vaccine schedules application that's available from CDC to download onto your cell phone. You can put in your patient's age and medical conditions, and it will let you know which vaccines are indicated. The American Academy of Family Practice also has an app. When I checked a couple weeks ago, they had not updated it with the 2020 changes, but presumably that's in process. So you can take a look at those and see which one you like best. And again, we all know that when you're running around in a busy clinic in between patients, it's definitely often not the best time to figure out which immunizations your patient needs, especially when there are complex issues with the schedule. So that's why it makes sense to put in some time trying to familiarize yourself with it. So let's move on to the next slide. Okay, so the ACIP adult schedule, the main information of the schedule is contained in two tables. The first table sets forth adult immunization recommendations by age group. And what you'll see here is that the main colors in the schedule are yellow, which means that a vaccine is recommended for adults who meet the age requirement, and purple, which means that at the age the person is, they can get the vaccine, and it may be indicated depending on what their other medical issues or other indications may be. New in 2020 are some blue boxes in the schedule, and these boxes indicate that this vaccine may be recommended in the context of shared clinical decision-making. That phrase, shared clinical decision-making, is a new one in this year's schedule, and we're going to spend a little bit of time getting familiar with that in this webinar. Next slide, please. Okay, so let's talk about age-based recommendations. So this is not complete, but it's letting you know some of the big players with age-based recommendations. You'd see the table for the full details. So flu and every 10-year booster of Tdap or TD is recommended for everyone, all adults of all ages. For adults that are 26 years old and younger, HPV vaccine is recommended if they have not already received it. And we're going to be talking a little more about a change to this recommendation to harmonize the recommendation for young men and young women in the upcoming slides. For adults greater than or equal to 50 years of age, zoster vaccine is recommended. And for adults greater than or equal to 65 years of age, PPSV 23, otherwise known as Pneumovax, is recommended. So these are some of the key age-based recommendations. Next slide. Okay, Table 2, I think, can be a little more challenging. Table 2 is the recommended adult immunization schedule by medical condition and other indications. So as you can see, you really need to consider both tables for your patient. Because they may be due for some vaccines based on their age and other vaccines based on their medical condition or other indications. And there are more colors in this slide. So we have the yellow, which means the vaccine is recommended. We have red, which means the vaccine is actively not recommended or contraindicated. We have orange, which is a precaution, which means it may be indicated if benefits outweigh risk. Obviously, that's going to be an individually tailored decision. We have pink, which I believe is new either this year or last year, and that has to do with a recommendation to delay an immunization until after pregnancy. The one I really want to call your attention to here is HPV. There may be young women in your practice who haven't been immunized against HPV, who are within the age group that should get it routinely, and it's sort of a placeholder that you would want to catch them up on that after they deliver. Then the purple again is a recommended vaccination if there's an additional risk factor or other indication. So you'll see listed across the top of this this table in black the various medical conditions and other factors that can lead to specific vaccine recommendations. So depending on your patient's issues, you're going to want to look down the column to see which vaccines may be indicated for them. And we like to think of these, if you can go to the next slide, like to think of these indications in 4 categories. At least I've found this very helpful, and I hope you will too. So the first category of indications are various chronic diseases, and these are chronic diseases that put people at higher risk for specific infections, and so specific vaccines are recommended. There may just be one, there may be several. Another, if we move to the right, are conditions that cause an immunocompromised state. These would be conditions that affect the immune system or perhaps immunosuppressive medications. So the main ones here would be HIV infection, non-HIV immunosuppression. For example, many patients are on immunosuppressive medications for medical conditions such as rheumatologic conditions and asplenia, and we'll be addressing that in one of the scenarios we'll go through. The next category is behavior or social conditions. This would include men who have sex with men, drug use, homelessness. These may lead to specific vaccines being indicated. And finally, occupational indications, including immunization recommendations for healthcare workers and perhaps others who may be at risk for exposure due to where they work. Next slide. Okay, so what are the updates for 2020? There have been updates with respect to HPV vaccine, and we'll go through that on upcoming slides. Catch-up vaccination for all adults, male and female, up to 26 years, and then a shared clinical decision-making recommendation for adults in the next age group. For PCV13, the ACIP has moved from a universal recommendation to a shared clinical decision-making recommendation for non-immunocompromised adults in the greater than or equal to 65-year age group. And then hepatitis A now has a routine recommendation for people with HIV, and a 2019 recommendation was made for hepatitis A vaccination for all people experiencing homelessness. Next slide. Okay, so let's talk about shared clinical decision-making. So really the basic point is that shared clinical decision-making means there's no default for whether or not to vaccinate. There's no right or wrong decision about immunization for a patient when shared clinical decision-making is indicated. The decision about whether or not to vaccinate is based on both the provider's discretion and an understanding of the individual patient's characteristics, values, and preferences. But it is helpful for providers to understand which specific patients may benefit most from the immunization. And the question of immunization does not have to be raised with each patient. It's really up to providers to decide whether to raise the issue. But of course, patients may raise the issue too, so providers should be ready to have those discussions. And CDC has a very nice shared clinical decision-making FAQ document, which is linked here, that you might like to take a look at for more information. Next slide. Okay, so let's talk about HPV vaccine. So the old recommendation, which you see here on the right-hand side of the table, is that for young adults who are not previously immunized, that men up to age 21 and women up to age 26 should receive catch-up vaccination. Now, catch-up vaccination is recommended for all adults up to age 26. So there's been a harmonization of the recommendations for men and women, which I think is very, very helpful and just kind of makes things a lot simpler. What's new also is a shared clinical decision-making for adults 27 to 45, and we'll discuss a little more about that on the next slide. But, and this, I think, has received a lot of attention because it's new and it can be, I think, a little daunting to think about how to implement this. So I want to really keep our focus on what is the public health priority around HPV vaccination. And really it is, if you're talking about a pediatric age group, it is immunization of boys and girls at the appropriate age as part of the pediatric schedule. And if you're talking about young adults, really it's catch-up immunization of young men and women. Okay, next slide. So when we think about shared clinical decision-making for HPV, what's important to know is that the ACIP did not recommend catch-up vaccination for all unimmunized adults aged 27 to 45 years, but they did want to preserve the option for some adults in this age group potentially to receive immunization, with the understanding that the public health benefit of HPV vaccination in this, let's say, older young adult age group, I'm not sure exactly how to call 27 through 45, but the public health benefit of HPV vaccination in this age group is minimal. These are mostly individuals who have already been exposed to HPV, and so the immunization is not going to do much for them. However, the ACIP is recommending shared clinical decision-making because there are some individuals who are not fully vaccinated who might benefit. And really those considerations include their likelihood of past and future HPV exposure. So really the people who are most likely to benefit from this are individuals who have not had prior HPV exposure but may have it in the future. Okay, next slide. All right, let's talk about PCV13. So the old recommendation on the right side here for PCV13 was routine vaccination of non-immunocompromised adults age 65 years and older. The new recommendation is for shared clinical decision-making for non-immunocompromised adults in this age group. So what's behind this change in recommendations? Really, there has been a decreased burden of pneumococcal disease among older adults. But rather than resulting from the immunization of older adults with PCV13, the data really shows that this decreased burden of disease is due to an indirect effect of the pediatric PCV13 immunization program. And at this point, the PCV13 serotypes account for a very, very small amount of the disease burden of pneumococcal disease in older adults. And so it's thought that there's minimal public health benefit of PCV13 vaccination in this age group. Now, please note that immunocompromised adults should still be immunized. This recommendation really applies to non-immunocompromised adults. Next slide. Okay, and this is just a graphic demonstration of what I told you on the last slide. And if you take a look at the middle line here, which says PCV13 introduced in children, what you see is that invasive pneumococcal disease was going down in the older age group, and it continued to decline. And that applies to all invasive pneumococcal disease, which is the solid line, and then also the PCV13 serotypes, which is the dashed line on the bottom. Okay, when PCV13 was introduced in adults age 65 and older, it really didn't change the curve. The dramatic decline had already happened, and that seemed to happen with the introduction of PCV13 in children. So I guess what I would say is, you know, there was a thought that it might very well continue to decline further, but in fact, it seemed that the improvement that was going to be seen was seen already with the use of PCV13 in the child population. Next slide. So if we think about shared clinical decision-making for PCV13 for non-immunocompromised adults age 65 and older, what we're looking at is that the risk for PCV13 type pneumococcal disease depends on the person's underlying medical conditions and also their risk of exposure. So in talking with some experts and getting some expert thoughts about this, it really seems that the groups of special concern include residents of nursing home and long-term care facilities and patients with chronic conditions such as heart, lung, and liver disease. They still have a low risk for PCV13 type pneumococcal disease, but the risk is a bit higher. So there might be more consideration of the immunization for those individuals. And again, it's going to be a patient-by-patient decision, or at least that's what ACIP is suggesting here. Okay, next slide. All right, I wanted to just, I have one slide here on MMR and one slide here on varicella. I just wanted to mention these vaccines because there are rows for them in the immunization schedules, both in Table 1 and Table 2. And I'm not going to mention them much in the scenarios because I'm going to assume that these have been sort of dealt with routinely in the course of primary care. So I thought I'd just mention a few things quickly about MMR and varicella. So first of all, according to the adult immunization schedule, 1 MMR dose is recommended for adults born in 1957 or later if they don't have evidence of immunity. And evidence of immunity really is either a positive serology or a record of having been vaccinated. So the thing that I think tends to be tricky in clinical practice is that most adults or many adults don't have that evidence or documentation, but most adults have been immunized. So I think the question that a lot of primary care providers have is how to handle that. That hasn't been coming up so much recently because measles hasn't been in the news as much in the very recent months, but certainly when there is measles circulating in the community, this can come up more. So a couple of thoughts here. The first is that adults born after 1970 who attended school in the United States are likely to have been immunized because schools had immunization requirements during those years. So that may provide some, at least, reassurance if the patient has attended primary or secondary school in the United States and was born after 1970. Adults born outside the United States before 1970, so now we're talking before 1970, are also likely to be measles immune. Excuse me, it's not certain, but it is more likely because they are likely to have been exposed to measles during the course of their childhood. Providers can always check IgG or serology depending on whether they wish to. It's also acceptable to immunize even without checking serology if there's no documentation of prior MMRs and no contraindications. I do want to note that there are some groups who should have 2 documented MMR doses. These include healthcare workers, college students, and international travelers, because measles is circulating in many countries around the world. Next slide. Okay, let's talk about varicella vaccines. So when we think about varicella vaccine, 2 doses of the vaccine are recommended for adults born in 1980 or later, unless there's evidence of immunity. And as you see on the right-hand side here, evidence of immunity can be obtained in 4 ways. Either if the person's born in the United States before 1980, if they have documentation of 2 doses of vaccine, or if they've been diagnosed with either varicella, chickenpox, or zoster, shingles, by a healthcare provider, or if there's laboratory evidence of immunity or disease. So if there are no contraindications, again, as with MMR, it's acceptable to immunize if there's no evidence of immunity. And healthcare workers and postpartum women, however, should have evidence of immunity or 2 doses of vaccine. Okay, and in that case, you wouldn't worry about where and when they were born as being a reason they shouldn't be immunized. Okay, next slide. Okay, so when patients don't have records and they don't know if they've received certain shots, you are allowed to accept their self-report for having received influenza and having received PPSV23 or Pneumovax. Those are the only vaccines for which self-report is acceptable. It's important not to postpone vaccination because you may miss your opportunity to immunize. So if you're unable to locate immunization records within a reasonable time, you should go ahead and start on the ation-appropriate immunization schedule. Serologic testing for immunity can be an alternative to vaccination for certain antigens if the person's fairly certain they've received the vaccine, and you can only check immunity for certain of the vaccine-preventable diseases. And certainly it is always acceptable to immunize rather than checking serology, especially if follow-up or cost is an issue. Next slide. All right, so let's go into some scenarios. And you may like to follow along with these and look at the schedule yourself to see what you think the patient's indicated for, and you can follow, I think this link to the adult immunization schedule should work on your screen if you hover over it and right-click on Open Hyperlink. The other thing you can do is just Google 2020 ACIP adult schedule and you should get to it. Next slide. Okay, so scenario 1. Andre is a 28-year-old man who is sexually active with men and women. Which vaccines do you recommend? Okay. So take a look at the table and see what you think, and we will go through it. So Andre is, I think we said he was 28 years old, 27 or 28. So he's in the 27 to 49 year age group. Okay. So looking at the adult immunization schedule by age group, we know he's due for flu. He may very well be due for Tdap if he hasn't had a dose. A booster in the last 10 years. And then what we see down here is that he may be a candidate for HPV immunization based on shared clinical decision-making. On the other hand, he may not. He may have already been immunized also. That's what we hope has happened. Okay, next slide. He is also in the men who have sex with men category. So again, we know he should get flu. We know he should get his tetanus booster or Tdap booster. He may be due for HPV vaccine, and then he's also indicated to receive hepatitis A and B vaccine because he is MSM. And again, he may have already had these, but there really is nothing wrong with giving the immunizations to him if you're unable to figure out if he's already been immunized or not with some reasonable effort. Next slide. Okay, so this just goes through his recommended vaccines. Okay, next slide. Grace. So Grace is 30 years old, and she's hoping to get pregnant in the next year. She currently has the Mirena IUD. Which vaccines do you recommend? And I'm just giving you a few extra pieces of information about Grace in case these help you. Grace was born in 1990. Okay, she doesn't remember having had chickenpox as a child, and she doesn't have her childhood immunization records. And she immigrated to the United States from the Philippines about 10 years ago. So she did not attend school in the United States. Okay, next slide. Okay, so let's take a look at her age-based immunizations. So flu, Tdap, we know about these. These are the same as for Andre. Here I highlighted MMR and varicella, and I just wanted to call this out. To me, this opportunity to consider immunizations for Grace is really a wonderful opportunity right now. I'm almost looking at this as a preconception visit because we know she wants to get pregnant soon, but right now she's on a very reliable method of birth control, and it's a great time to really make sure that she's up to date on her rubella and her varicella immunization. Again, shared clinical decision-making for HPV if this is felt to be appropriate. Okay, next slide. So here are the recommendations for Grace. Again, flu and Tdap, MMR and varicella if no evidence of immunity, and HPV potentially can be addressed through shared clinical decision-making. Next slide. Okay, Lucy is a 55-year-old woman with diabetes and asthma. Which vaccines do you recommend for her? So now we're getting into some of the chronic conditions that can lead to the recommendation for specific vaccines. So let's take a look at the table. All right, so for table 1, she is in the 50 to 64-year-old age group. So again, flu, most definitely recommended. TD or Tdap, most definitely recommended. And then she's in the group that is recommended to receive the recombinant zoster vaccine, that's otherwise known as Shingrix. Most of you probably know that if your clinic doesn't stock this and Lucy has Medi-Cal, she can be referred to a pharmacy to receive that. It's a Medi-Cal pharmacy. All immunizations are a Medi-Cal pharmacy benefit, but this is something that clinics may specifically be interested in doing if they don't stock Shingrix. Okay, next slide. Let's take a look at the indications. So Lucy has both heart disease and diabetes. Actually, can you go back 2 slides, please? Thank you. Okay, sorry. She has. I just wanted to get my conditions correct. She has diabetes and asthma. Can you move forward again? Thank you. Okay, so she has lung disease in the form of asthma as well as diabetes. Okay, so we're going to look at both columns, and because it would get too busy and confusing, we put the recommended vaccines over here on the left. You'll see the green check marks on the left. So I'm just going to move down one by one. Okay, so we know she's indicated for flu shot and for her Tdap or TD booster if she's due for that. Again, her recombinant zoster vaccine, these are all the age-based recommendations. Then, if you take a look at the heart, lung, or lung disease column, what you will see here is that she should get a PPSV23. You see that that's yellow here. She should get a PPSV23 based on that condition. Okay, she's also indicated for PPSV23 based on her diabetes, so she has two different chronic conditions that mean that that vaccine is indicated. And then if you move down, you also see that because she has diabetes, she's indicated to receive hepatitis B. Next slide. Okay, so if you take a look at this, what this all adds up to is she should get flu, she should get her every 10-year Tdap/TD booster, recombinant zoster vaccine if she hasn't yet received it, and then PPSV23 and Hep B due to her diabetes, and in the case of PPSV23, also her lung disease. Next slide. Okay, so Jonah is a 38-year-old man with sickle cell disease. Which vaccines do you recommend? So this is actually a little bit of a trick question, which it may be for some of you. And it is because patients who have sickle cell disease don't have a functioning spleen. One of the consequences of sickle cell disease is damage to the spleen. And the spleen is a very, very important immune organ. Asplenia, which you see in the black highlighted column here, is another word for not having a spleen, okay? Some people have had the spleen removed because they've been in a car accident or something like that, some other kind of trauma. Some individuals don't have a functioning spleen due to a medical condition, and that's the case for someone with sickle cell. So this scenario is meant to highlight some of the specific immunizations that are recommended for individuals with asplenia, okay? So again, as we've been looking at the age-based table, we're not going to go over it again here, but he is due for a flu vaccine and potentially his Tdap or TD every 10-year booster. And then there are some specific immunizations that he needs because of his asplenia, and these are listed below. So PCV13, PPSV23, the quadrivalent meningococcal vaccine, the ACWI meningococcal vaccine, the Men-B vaccine, and a Hib vaccine. Okay, it's quite unusual for an adult to be due for a Hib vaccine, so we really wanted to highlight this here. These, the pneumococcal bacteria, the meningococcal bacteria, and then the Haemophilus influenza bacteria are specific bacteria that are known to be very dangerous for patients who don't have functioning spleens. So it's actually really helpful and really lucky that we have immunizations available for those. Okay, next slide. Okay, so Jonah's got quite a list of recommended immunizations. I'm not going to repeat them all, but he's going to be very appreciative to get all of these immunizations that he needs to protect him from those bacterial infections. Okay, next scenario. Tanya is a 26-year-old woman who's a medical assistant. Which vaccines do you recommend for her? Okay. So she would be in the category that's on the far right here in this table, which is healthcare personnel, okay? And so for healthcare personnel, because they are taking care, they're both more likely to be exposed to communicable diseases, and also they're taking care of vulnerable patients who are at risk for serious complications of communicable diseases. So the recommendations for healthcare personnel are more stringent than for the general population. And you all know this because you know that you've had certain immunizations recommended to you as healthcare providers. So we're going to look at the yearly flu vaccine, the Tdap or TD booster. MMR and varicella are indicated for healthcare providers. HPV vaccination may be indicated for her depending on, because of her age, if she hasn't received the immunization yet, she'd be indicated for catch-up immunization. And then again, she'd be recommended to receive hepatitis B immunization because it's hepatitis B is a bloodborne pathogen that she may have some risk for based on her occupation. Next slide. Okay. And that just recaps this. And again, to remind you, the specific immunizations to have your eye on for healthcare workers are hepatitis B, varicella, and MMR. Next slide. Okay. This is rather a complicated scenario. Again, it's a little bit like the asplenia scenario because you really need to pay attention to the table, and this is someone who's going to end up actually needing a lot of immunizations, potentially depending on what he's already had. So Luis is a 50-year-old man with HIV, and he has a very low CD4 count, cirrhosis, and COPD, which stands for chronic obstructive pulmonary disease. It's a type of lung disease. He's also MSM. Which vaccines do you recommend for him? Okay, so again, we put the check marks over on the left-hand side here just so it wouldn't get too confusing. But when you look across the table, there are actually 4 different columns that apply to this patient. So it's a bit challenging to go through it, but this is a patient who it's very important to immunize. So he definitely needs his seasonal flu vaccine. You're going to consider his 10-year tetanus booster. There actually isn't a recommendation regarding Shingrix in patients with HIV yet. I'm not sure if that's something that is in the works, so that's going to be an individual provider decision. When we're looking at PCV13, he is indicated to receive that based on his HIV infection. And he's recommended to receive Pneumovax or PPSV23 based on several of his indications. Again, hepatitis immunization based on HIV and based on being MSM, and then the meningococcal immunization based on his HIV infection. I just want to point out, I apologize, I just noticed an error in this slide. This slide has the 2019 schedule, so you don't see a yellow box for hepatitis A for HIV. That's a new 2020 recommendation, so my apologies, we didn't change out the table here. But he is definitely recommended to receive hepatitis A. So these are a lot of immunizations, and there may be some individual considerations that the provider may have about the timing of these, but the point again is that it makes sense to spend some time sorting through this to make sure that this patient can get what he needs. Next paragraph, next slide. Okay. So again, immunizations listed here with multiple indications for certain of the immunizations. If you can go back, one last thing, if you can go back to the prior slide for just a second. I just want to also point out that there are a number of immunizations that are contraindicated for this patient and for other individuals who have immunocompromising conditions, and these are indicated in red here. So I think this is something that providers are quite used to paying attention to, but I just wanted to call your attention to the immunizations that are contraindicated for him. Okay. Thank you very much for your attention, and I think we're going to move on to VFA program updates.
Thank you, Dr. Hoover. We'll quickly run through program updates, and then we will open it up for questions that you may have for Dr. Hoover or anyone here working on the VFA program. So VFA, we have 409 providers in the program. That's all of you. Thank you so much for all that you do for your patients. We're happy to support with the vaccines that we offered for you, but it is always a pleasure to see all that you're able to do out there in your clinics. So many of you completed the evaluation for 2019, and we have taken that data, we have analyzed it, and we plan to share some of that data with all of you on the next webinar, which will probably be scheduled this summer. July, I believe, is usually when we hold the second webinar. And then as a reminder, last year we had 30 quality assurance visits scheduled. We will have a similar number of visits scheduled in 2020. You will certainly get some advance notice when these visits will occur. It's just a small number of sites across the 409. So we just want to make sure that you're aware that there are some visits that will be scheduled this year. So this is something that has come up recently, and we wanted to take a little bit of time to talk through it and explain it to all of you and remind you. We know that staff turnover happens in every clinic all the time, and that when thinking about your VSA coordinator, that we really, when you make these changes in your EZIZ page, that you need to make sure that the new person who will be listed as a VSA coordinator has taken all the required EZIZ trainings. I know everyone has taken the trainings recently for recertification, but if you've had staff changes since then, anyone who is designated as VSA coordinator will have to do the required trainings before they're even listed in the menu from which you can pick a VSA coordinator. And we know that it does take a little bit of time to do the trainings, but we do want to make sure that that person is well informed on everything that's related to storage and handling of vaccines. And we need to make sure that the contact info that we have for VSA coordinator is up to date as well. And it's really important for us as we reach out to all of you when we talk about our different VSA communications. We rely on the list that we get for VSA coordinators, and those are the folks that we reach out to and let them know about any schedule changes, anything that has come up recently, when the ordering periods open and close. All of that information goes to the VSA coordinator. So that's why it's really important to make sure that this piece of information is up to date in your MyVSC Vaccines profile. Okay, so we wanted to just share a little bit of data from 2019. These are the doses, vaccines that you've ordered in 2019, and to no surprise, Tdap is the #1 vaccine. It always is. I think it is every quarter and probably will be for a very, very long time. We have seen hepatitis B increase, and we've also seen Shingrix increase as well. And we think part of that has to do with the more readily available supply, both on the private side, which I think has resulted in just more doses being ordered through VSA as well. But just a reminder of kind of the quick look at what ordering looks like for the VSA program. So again, just sort of taking a look at what we saw in Q1 of 2020. Similar pattern again with Tdap being the most popular vaccine, followed by zoster this time, so Shingrix, and then hepatitis B vaccine. So in terms of updates, the next ordering period is scheduled April 6th through 17th, and we will use our VSA coordinator contact list to let you know when the ordering officially opens. And then we wanted to just mention to you, I showed you the previous slide with sort of the ordering that we've seen in 2019 and the first quarter of 2020, is that we are working with a budget. So the VSA program is very different from the VFC program. The VFC program is an entitlement program. The VSA program is a 317 budget, so we work within a budget amount, and we are very closely monitoring ordering of 3 vaccines in particular. They happen to be the more expensive vaccines, so PCV13, HPV, and herpes zoster. PCV13 and HPV are perhaps the two that we know ACIP recommendations have changed, and we want to take that into consideration and want to see how the ordering continues. So Dr. Hoover did a great job of describing the recommendations, and especially with the shared clinical decision-making that goes into play, but that this is certainly something that we are taking into consideration as we look at the ordering for those 2 PEP vaccines. And then Shingrix is, I think, it is a popular vaccine as well, and so these are 3 that we are keeping in mind and keeping a careful eye. And so When you do your ordering in the second quarter, you may be limited in how many doses you can order of these 3 vaccines. More information will come out right before ordering, so you'll have enough information in front of you before you place your orders. And then as a reminder, and this is something that we included in the last couple of clinical letters, most of the manufacturers have a patient assistance program in place. I think many of you used that before the VFA program came into existence. So it's programs that allow clinics like yourself to collect, to offer certain vaccines and then get those vaccines not reimbursed, but restocked from the manufacturer at no cost. So the manufacturer will give you back a dose, replace a dose that you've given to a certain patient population that is uninsured or falls below a certain poverty line. So that information is available, and we will work on getting more specific information from manufacturers available and sent out to all of you. Okay, so with that, I'm going to turn it over to Anya for a quick update on provider resources.
Good afternoon, everyone. I just wanted to let you know about some of the resources that are available. We've included links to these resources to support you in implementing the latest ACIP recommendations. This includes a webinar and the FAQs that Cora mentioned on shared clinical decision-making for immunization. So I encourage you to review those resources and discuss them with your adult immunization staff. I also wanted to highlight some patient resources. The VFA poster, which you guys all know about, that's been updated, and we've also recently translated it in 16 additional languages, which you can see listed below. Those are now available to download, and those are all listed also on the VFA UCIZ page. If you type in bit.do/VFA resources, or when we send out the slides, the links are there too. You can get to the VFA resources page too, and it's under the popular links. And then there are a couple other resources I'm just highlighting that we've had that are great for your adult immunization programs as well. One on shingles in English and Spanish, and then one on the pneumococcal vaccines in English and Spanish. Thank you.
Thank you so much, Anya. So at this point, we are finished with our 2 presentations. Why don't we, I'm looking to Christina to see, have we any questions come in via the chat box?
No questions in the chat box.
Okay, so if you have questions, feel free to go ahead and place them in the chat box. We now will open all lines. So if you don't have a question, go ahead and self-mute right away. But we'll go ahead and open lines. That way we can answer any questions you may have for Dr. Hoover around the adult immunization schedule, or any questions about the program. We're happy to answer any questions at this time. So Cecilia, will you...
Yeah, they have to really close. Literally took me 20 minutes.
All right. Cecilia, do you want to go ahead and close the lines for now? Thank you. If you can raise your hand, I believe that is the other way to open lines, and we can answer questions that way. Checking to see if we've had any questions come in yet. We do have one question.
We have one question. Is the HPV vaccine for adults over 26 okay to give?
So I don't know, Dr. Hoover, do you want to answer that question within the context of shared clinical decision making?
Very well, if you wouldn't mind repeating.
Oh, yes. Go ahead, Christina.
So the question is the HPV vaccine for adults over 26 okay to give?
So the question is about HPV vaccine being okay to give for adults over the age of 26, correct?
Yes.
Yes. So for adults in the and we can go back to the slide on that in the presentation. So for adults older than 26, a shared clinical decision-making model is used. And sorry, we're going through a lot of slides here. So it is acceptable to give it, but again, this would be an individualized decision really based for patients aged 27 to 45 years, based on individual considerations that include the likelihood of past and future HPV exposure. So it's fine to give it to someone in this 27 to 45 year age group, again, if their individual considerations lead to that decision.
And just as a reminder, the public health benefit in this age group is pretty minimal. So I think that while it is okay to give it to someone in that group, the sort of benefit of vaccinating is certainly an individual decision.
And I think the key word in this is individual, because it is okay to give individually. I think one of the things that we will really hope that you're looking in your practice is that it's not a routine vaccine that should be given to all patients, you know, of 26 to 45 years of age, 27 to 45 years of age. So it should be an individual decision.
Thank you, Nisha and Claudia. That's exactly right. We really want the focus to remain on getting the younger age groups immunized.
Great. So a related question that came up, is HPV vaccine covered by insurance for those over 26 years of age, so covered by Medi-Cal or private insurance?
As far as we know, yes, it is. The managed care plans, the Medi-Cal managed care plans are covering the vaccines, and as far as we know, private insurers are as well.
Another HPV question. If a patient who is 27 to 45 meets the recommendation for HPV and has not gotten any previous HPV vaccines, do we complete the 3-dose series?
So again, this goes back to prioritization and shared clinical decision-making. Again, the public health benefit of immunization in this age group is minimal, and we're really focusing most of our efforts on the younger age group. That said, if shared clinical decision-making leads to an individual decision to vaccinate that patient, then they would get the full series.
Have any other questions?
Somebody did raise their hand, so maybe we can unmute the line for Eduardo Rivera.
Cecilia, did you hear that? We have a question from Eduardo Rivera. You can unmute their line.
Eduardo, line is open.
Okay. Go ahead with your question. Hi.
Hi. I was going to ask about the HPV or something similar.
Okay.
I received a paper where they actually get 3 doses after the 26 years of age. So they actually get 3 doses, right? They get the first dose, and then the second dose, and then the 6 months after they get the 3rd dose, right?
Yes, it is a 3-dose series.
Okay.
I don't know, Dr. Hoover, is there anything else you want to add?
Thank you.
No.
Okay, thank you. Any other questions?
So another question that came up is, my clinic currently supplies VFA vaccines for Tdap, PCV13, and Pneumovax. Where can I send my patients for other needed vaccines? Do you have a list of other public health clinics that could vaccinate my patients at no cost?
Okay, so right now, when you go in for ordering, you should be able to see all the vaccines available, and there's no reason not to order the other vaccines unless there's a decision made at the clinic level to only provide certain vaccines. But having said that, local health departments do have limited supplies, but again, it's very limited. Uninsured adults can come to you or a health department, but we recommend that you store all the vaccines that we make available for you, for your patients. for your uninsured patients.
And one more question came in. When will there be an open enrollment for a clinic to sign up for the VFA program?
It's $1 million question. VFA is, so we mentioned that we have 409 providers now, and our 409 providers, all of you are doing a wonderful job of utilizing the vaccine available, and as a result, we are actually at capacity in terms of offering vaccine. There isn't really an opportunity at this point to add on any more clinics because we are using every single dollar in our budget right now to provide vaccines to all of you. If there are any changes in the program, we will certainly reconsider enrollment, and then there will be ample opportunity, and we will make sure everyone knows when enrollment opens up for other clinics. But right now, there is no open enrollment for VFA.
No other questions?
No other questions. That leaves us with exactly 2 minutes. So with that, we will go ahead and end today's call. Thank you so much, Dr. Hoover, for presenting on this schedule, and thank you to all the VFA providers. I know you are all extremely busy right now, so we appreciate you taking the time out to call in. And should you have any questions, our last slide has the My317 email address, so feel free to send questions that way. And
my317@cdph.ca.gov.
Thank you. And just as a reminder, you will be getting an email from us. There will be an evaluation of this webinar, and then there should be in the next few weeks an update on VFA ordering for Q2. So hold on, I think there's one final
I just wanted to make one comment, Ms. Rebecca, and Dr. Hoover, please correct me if I'm wrong. I just wanted to make a clarification because there were so many questions about HPV vaccine. So for 9 to 14-year-olds, you only give 2 doses, right? One and then the second dose at 6 to 12 months after the first dose. For those over the age of 15, they get 3 doses. The second one given 1 to 2 months after the first dose, and the third dose given 6 months later. So I just wanted to make sure that there is that understanding of the 2 different dosing schedules.
Thank you, Rebecca. Okay, well, thank you very much, and we will end today's call. Thank you. Goodbye.